All right, so 400. That's a good number.
Hi guys.
Nicolas?
Yeah, how are you?
I'm good. I'll be better if I could see your face, man.
Oh, where's my camera? How can I do it? Auto. Come on.
There you have it, the right upper corner. Let me put on
Hello, hi.
webcam request and to Pedro as well. Have you got it?
Yeah.
There you go. Okay.
Excellent.
Great. Good
Hi,
to
guys.
see you guys.
All right. Hey, guys.
Hi.
Good to see you all.
What are you drinking, JP?
It's not beer. It's just Coke.
Oh, Coke. Okay.
Yeah.
It's getting hot there.
Yeah, I mean, the weather's pretty nice. It's 22 to 25 degrees. Yeah.
That's good.
Very beautiful morning. And we're getting more and more traffic, so that sucks. But you know, it's all good. It's all good, you know. We're still having, you know, like 10, 20, 30 cases every day. But everybody's just saying fuck it and they're all partying, man.
Really?
Yeah.
Oh. Today we had 4,100.
Oh.
Terrible.
Oh, wow.
Just for today.
Yeah.
4,000 new cases just for today.
Exactly.
Oh, so you guys are just starting.
Yeah, and it's not good. All the ICU, it's almost full. Very, very, very crowded. Collapsing the system.
Well, let me tell you, take this time to do something that you wanted to do for a long time, because you're going to be out of action for a couple of months. And you know, and I don't know, I mean, you know, of course we go see, you know, like, you know, COVID patients too, but you know, we gravity, these lymphatic fluids do not have a backflow. So the intrinsic system of pumping through the smooth muscles, as well as these valves, make sure that the lymphatic flow is flowing in one direction. In addition to that, we have surrounding musculature and the surrounding muscle. When you walk or when you put strength in your leg or in your arm, it also pushes the lymphatic vessels to move along toward the heart, enhancing the circulation. So if you think about it, when people start to have lymphedema, compression, and under the compression, exercising to help that extrinsic pressure toward the lymphatics is very important in treating lymphedema patients. So in the end, these lymphatic vessels travel in their own pathway, and ultimately they go to the heart, and through these pathways, there's a lot of lymph nodes. So we have more than 500 lymph nodes in our body, and we use these lymph nodes actually to replace the lymph nodes. If we take these lymph nodes out, you want to do a lymph node transfer, and there are a lot of favorable positions or places that you could harvest the lymph. Now, if you also look at the lymph node, multiple vessels are collected into this lymph node, and then they have efferent going out vessels and ultimately reaching the heart. And then just before it reaches the heart, and through multiple lymphosome territories, it drains into the subclavian system. So we just talked about the basic flow and the anatomy of the lymphatic system. And the key question that you have to ask when you see a lymphedema patient is, where is the obstruction? So that's the key question that you have to ask. Because distal to the obstruction is where the lymphatic fluid accumulates. And the lymphatic fluid usually accumulates in the subcutaneous fat layer. So the fluid distal to the obstruction is accumulated in the subcutaneous fat, and that's what lymphedema is. Now, most of the lymphedemas that we see in our practice is secondary lymphedema, especially after cancer, in relationship to lymph node removal or in trauma where lymphatic pathways get injured. For example, in the lower extremity, this patient has cervix cancer, so she's removing lymph node within that intraperitoneal region, and thus you're removing the central lymph nodes, lymphedema could occur bilaterally. Sometimes it occurs unilaterally and then ultimately becomes bilateral. From the beginning, it could be bilateral. It really depends on where the most injury is. But nevertheless, the obstruction point is within that intraperitoneal cavity. For the arm, the lymph nodes are removed from the axilla. So this is why distal to the axilla, there is lymphedema. Now, in primary lymphedema, the pathology is a little bit different. First of all, it could be lymphatic agenesis. That means that there's no lymphatic system for the congenital lymphedema. Or they could have an anatomic defect in some part of their body. And when you see this, we have to realize, why is the primary lymphedema occurring? Because sometimes if they have the lymphatic system, but if it's dysfunctional, then you could still do LVA in primary lymphedema patients. However, if there's no lymphatic system, then you cannot do LVA. So you have to think about what is the pathology, especially for primary lymphedema. So in my experience, I would say around 70%, you're able to do lymphedema, LVA in primary lymphedema because it's dysfunctional. And in 30% of the time, there is actually no lymphatic system. Now, for the secondary lymphedema, we know where the exact point of obstruction is, and that's what makes it easier for us to think about what surgery options that we could have for these secondary lymphedema patients. Now, basically, because there's an obstruction and the fluid is not able to flow, and the fluid accumulates in the subcutaneous fat. If it accumulates and then there's a stagnant water, and this is why you have cellulitis, if the bacteria goes into that subcutaneous fat with a lot of fluid. And ultimately, if the fluid is not able to exit anywhere, it starts creeping through the skin. And this is why they have lymphatic fluid coming out of the skin, as you can see here in this photo, with a very chronic late stage 3 patients, as seen in this photo. Now, the secondary lymphedema mostly occurs, again, from the lymph node resection after malignancy. It could also occur from trauma, if you have, especially in the medial thigh or in the axilla. It also could occur from DVT and from radiation, as well as infection. So you have to know the exact cause to make sure that this patient will not undergo lymphedema. And at the same time, you have to also understand where is the site of the obstruction to actually think about how to approach. Now, the good news about secondary lymphedema is that when the patient has acute lymphedema, 85 to 90% of the patients will respond very well to just decongestive lymphatic therapy. So this is why when you see lymphedema in their early stage, we should send it to rehab. So they undergo compression therapy. And because when they go compression therapy, 85 to 90% will have positive response, and then eventually they'll get better. So the question I ask you is, if you see a patient in early lymphedema, is it reasonable to do LVA? Because we know that 85 to 90% will be good, will have positive response just by doing compression. So our protocol is that we always send acute lymphedema patients or stage 1 lymphedema patients to our rehab, and they undergo a compression therapy for a period of time. And if they don't respond after 6 months, this is when they're actually referred in having a surgical management. So this is why also multidisciplinary teamwork with your rehab makes a lot of sense. Again, 15% of these patients with acute lymphedema will have chronic lymphedema. And these patients, before the days of physiologic surgery, they had to wear some kind of compression every day during their life. And it's not only that kind of life quality that really decreases, but at the same time, they'll have 30% of recurrent cellulitis. Some of them will actually develop cancer, not to mention the dysmorphic appearance that they'll have by having elephant legs or elephant arms. So there's a lot of secondary complications that are very closely related, not only to the quality of life, but ultimately to the quantity of life as well. So we start to think, are we able to have a solution that is able to improve their quality of life? At the same time, are we able to do something to establish functioning lymphatics again? So these are the key questions. And if you look in literature, the first lymphedema case goes all the way back almost 5,000 years ago in the Egyptian kingdom. They actually have statues of kings having lymphedema. So this has been around with us for a very long time. And this is why early in the beginning, there was a lot of effort to treat lymphedema. And these efforts, because they didn't have the knowledge of the lymphatic system anatomy, at the same time, they didn't know a lot about the physiology, most of their treatments were focused in actually debulking. So remember, we talked about where the fluid accumulates, and the fluid usually accumulates in the subcutaneous fat. So if we get rid of the subcutaneous fat, that means theoretically there will be no place to store the fluid, and thus the patient will be free from lymphedema. And that's the basic idea for debulking. So here's a patient that underwent debulking long time ago at a different center, and then you could see that part of the places where it was less debulked had recurrence. So we basically went back and then we did additional debulking for the places where it was accumulating fluid, and the patient has a relatively good result. But again, this patient will have to undergo compression for the rest of his life. Now, this is a paper that I wrote with one of my mentors, Dr. Hung-Chi Chen from Taiwan. And this is the ultimate, the extreme form of debulking surgery. So what does it do? It's removing everything above the deep fascia, all the fat, and then basically harvesting the skin and then regrafting it on the deep fascia. So we're able to remove the entire fat component, and there's no chance for the fluid to accumulate in the fat. So yes, we solved the problem of lymphedema, and this patient will not need garments unless it's the toes or it's the upper thigh. However, if we look at the quality of life, this patient's not going to be able to wear a skirt for the rest of her life. Even though we fixed the problem, we created another problem, or in a problem related to the quality of life. So this is why we started to do a lot of liposuction. Now we're able to spare the skin, have a very good cosmetic appearance, and then we're trying to liposuck as much fat as possible. But the problem with this, of course, in some hands, they have great results. But the problem with this is that they need to compress again for the rest of their life as well. Now, liposuction in my hands, we try to do this in congenital lymphedema, where these patients do not have lymphatic system and are not indicated for LVAs. We do a lot of liposuction, and you can see this child here after 5 years of liposuction. We're able to maintain a relatively good contour with compression. However, this patient will have to undergo multiple more liposuctions while he's growing up. Another good way to manage acute cellulitis is incision and then basically draining the fluid. I think MPWT could work to give you a really quick fix. And here we made a lot of incisions. We opened up and we undermined the fat, and then we just hooked on the MPWT to drain the fluid. And then you have this kind of sudden result when the patient has acute cellulitis. This is the way we like to approach. And then you could see that there's a relatively large decrease in the leg size. However, again, this is not physiologic, so the patient will have to undergo compression therapy. Nevertheless, this works quite well in acute cellulitis settings. So we do use this time to time. But all these procedures regarding liposuction or temporary incision and drainage or partial excision, debulking, they need to use a compression for the rest of their life. So this is a huge quality of life issue. So is there a way we could do it better? And this is where reconstructive surgery, especially supramicrosurgery, the idea comes in. Because remember, ultimately, the lymphatics drains to the subclavian vein. So if we're able to hook up the lymphatics to the vein, distal to the obstruction, theoretically, we'll be making a bypass and the fluid will be able to drain. So using these kind of idea and reconnecting the lymphatic to vein instead of near the heart, near the subclavian vein, distal to the obstruction, we're able to have a flow, exit of fluid from that upper or lower extremity. So establishing the flow is basically two ways. In my hands, lymphovenous anastomosis. And then we also do a lot of lymph node to vein anastomosis, which we'll be talking about later on as well. Now, another way to approach is replacing what is missing. So, for example, if they remove the axillary lymph node, we transfer a lymph node flap into the axilla, creating a lymph node and hoping for lymphangiogenesis and ultimately recreating a lymphatic flow through the flap. So replace what is missing by doing a lymph node flap is that kind of idea. Now, the lymphatico-venous anastomosis and sometimes lymph node to vein anastomosis and sometimes lymph node flap, it all requires microsurgery. But in addition, when you're manipulating smaller vessel, you have this concept called supramicrosurgery where we're manipulating small vessels 0.3, 0.5, less than 0.8. And if you have the luxury of having new instruments, that's great. Now, supramicrosurgery created another category where we're using smaller sutures, smaller instruments. In addition to that, smaller equipment and instruments, we now have microscopes with special imaging techniques like using the ICG. And this is what really makes possible of doing this kind of LVA, lymphovenous anastomosis, and doing supramicrosurgery. So I'll briefly go through that three categories of LVA and then lymph node to vein and then lymph node flap, just to give you an idea what this is all about. Now, this first video is lymph node to vein. This first video is lymphovenous anastomosis, and you could see right beneath the dermis, you could actually see this lymphatic vessel. And you could use multiple dyes. In this case, we used immunofluorescent dyes. This is a very common dye used by ophthalmic colleagues. And that was a 6-0 nylon right next to the lymphatic vessel. So you could see how small it is. And because there's high pressure in the lymphatic system, by connecting the high pressure lymphatics to the low pressure vein, you're able to actually create a drainage of lymphatic fluid from high pressure to low pressure vein. I like to do both sides, proximal and distal, because once the lymphatic pressure builds, the valvular function, the valve doesn't function anymore. So there's actually a lot of backflow. So by connecting proximal and distal, you're actually allowing the fluid to exit from both distally and proximally. And this is how to use that subdermal, very superficial lymphatics to do LVA. And this is the typical way that Dr. Kochima approaches. So again, you have to think about why LVA works. And the reason it works is it's using a pressure gradient. Now, the normal vein, when you're lying down, the capillaries is about 20 millimeters mercury. At the groin, as it goes near the heart, the pressure goes down. The groin is about 8 to 12. In the abdominal cavity, it's about 3 to 5. And in the right atrium, near the axilla, is around 2. So in a way, this is why upper extremity actually has better result than lower extremity, because the upper extremity venous pressure is much lower than the lower extremity. However, when you're standing, the pressure goes up significantly to about 90 to 110. And then, but however, when you move, the pressure goes down to about 20. So this is why after LVA, we have to tell our patients to exercise, because we're using that extrinsic muscle power to actually pump the lymphatics at the same time, allow the veins to suck up these lymphatic flows into the vein. So this is why post LVA, we have to recommend doing a lot of exercise. Now, the lymphatic pressure, the normal lymphatic pressure is usually 12 to 70 millimeter mercury. So this is why even in normal people, when we stand for a long time, your leg swells, because the venous pressure when you're standing and you're not exercising is higher than the lymphatic pressure, and the lymph back, and that's why it causes swelling in the leg. However, when you sleep, the venous pressure goes down to about 20, and then the high lymphatic pressure is able to drain to the venous system, and this is why the swelling goes away at night. Now, however, when you have lymphedema, the lymphatic pressure goes up all the way higher than 200 millimeter mercury. So it makes sense to connect the high pressure lymphatics to the low pressure vein in lymphedema patients. And also, it makes sense to compress externally to allow that muscle to squeeze the lymphatic system and also to decrease the venous pressure to deliver a better lymphatic flow after you do the LVA. And this is how this is the idea of doing LVA in perspective to understanding these pressure gradients that are created during standing, lying down between the vein and the lymphatics. Now, as the lymphedema patient becomes more chronic, we briefly talked about how they lose the valve function in the lymphatics. In stage 0, you see that this is a very translucent, very small lymphatics. But when you see that obstruction, the lymphatic starts to swell up because it's collecting more fluid and you cannot exit. So it's swelling, it's becoming ectatic. And then as it becomes ectatic, it starts to go under contraction of the smooth muscles. And the smooth muscles actually turns very fibrotic. It's like atherosclerosis because of high pressure. And then ultimately, in stage 3, there's so much contracture, there's so much fibrosis and sclerosis that the lumen is almost impossible to find. So this is the reason why they said in stage 3, because of the fibrosis, aggravation of the lymphatic vessel, that you should not do LVA. However, we'll be discussing a little bit more on that and why I disagree with this, partially disagree. And if you look at the cross section for stage 1, early acute, and then stage 2 and 3, you can see that the lumen becomes smaller and smaller to a point that you're not able to actually see any function in these lymphatic vessels. So theoretically, it would be the best to actually find these kind of dilated lymphatics to hook up your vein. So that would be the best way to do so. So again, when we do LVA, we saw the first video clip. You could actually do it to find these small subdermal lymphatics. However, if you go in deep to the subcutaneous fat, you see larger lymphatics. So we always try to aim to go into that deep tissue, into that subcutaneous fat, and always find these larger lymphatic vessels. As you can see here, it's about double or triple the size. So it makes your microsurgery much easier. So the ideal lymphatic vessels for you to find is the one that's deeper because it's anatomically larger. At the same time, find these dilated or ectatic lymphatic vessels because they have a large diameter and the lymphatics is still functioning. It just makes it an easier anastomosis. What about the vein? What is the ideal vein? The ideal vein is whatever is available. First of all, because sometimes we find good lymphatics and we don't find vein, so we're not able to do the anastomosis. Second is you want to have less pressure. The less pressure the vein has, the minimal backflow the vein has, the better the flow would be. So try to find the one with a minimal backflow. And of course, that means low pressure as well. Nowadays, I added on to saying the ideal vein is a branch from a large vessel. Because these branches, when they go into the vein, it actually sucks in because of the venturi effect. And to create the venturi effect, of course, there's many ways to do the anastomosis. There's end-to-end, and then you could do side end. This is the lymphatic, and this is the vein. You could put it in the side of the vein, or you could do end to side. So you could do actually side of the lymphatics into the end of the vein. I like this the best. The side of the lymphatics to the end of the vein because you're collecting flow from both sides, distally and proximally. Because remember, these high pressure lymphatics lose the lymphatic valvular function. So there's actually flow from distal and proximal. So instead of doing two sides end to end, nowadays I just open the side of the lymphatics and plug in the vein to the side. And then of course, there's also a way to do it side to side. So these are the multiple ways to do the anastomosis, side to side, end to side, side to side, or end to end. So there are multiple ways to do this. But again, the point is you want to find that ideal lymphatic vessels that is large in the subcutaneous fat and also is relatively dilated. For the vein, the ideal vein is to find whatever is close to it and then whatever has minimal backflow. So you're able to hook up the lymphatics into that vein. So here's the multiple ways to do it. And of course, using this ICG camera also lets you see whether or not you did a good job and the function is still there. So here's what I mean by venturi effect. Look how the lymphatics is being sucked into the vein. So the venturi effect is as the cavity becomes larger, and the side just gets sucked into the vein. So nowadays I try to find the branch of the vein, and then I hook the vein into the side of the lymphatics, which causes the venturi effect and allows to suck in the lymphatics as it enters the vein. So the ideal way for me nowadays is to find the vein branch, find the end, and then hook it up to the side of the lymphatic vessels, and doing and creating that venturi effect, and collecting lymphatics from distal and from the proximal. These are the typical LVAs that are indicated for stage 1, late stage 1, or stage 2, early and late. So again, most of our patients go through the rehab, and if they don't have positive results just from compression, then they're referred to us, and then we see dilated lymphatics, and typically we'll have good results for stage 1 and 2. This is a congenital testicular lymphedema patients that we did, and this was a direct incision into the scrotal skin, finding the lymphatic vessel, and then hooking up the lymphatic vessels, and this is at post 6 months. This is a foreign patient, so we don't have the last result, but I was told that this patient has a normal size now. But what about for stage late 2 or 3? Now, the consensus was that we shouldn't do it for stage 3, or some for stage late 2, because of the sclerosis and the fibrosis of the lymphatic vessel. Now, we took a closer look, and remember, this is a great paper by Dr. Mihara, the Japan group, and he shows through histology that when the patient undergoes stage 3, the lymphatic vessel undergoes fibrosis. However, what we found was that the lymphatics do not undergo staged change. Although the majority of the lymphatic vessels are in fibrotic stage, there are still good functioning lymphatics. So the goal for stage 3 is not to do LVA, but to find that functioning lymphatics. And once you're able to find that functioning lymphatics, then doing LVA in stage 3 becomes possible. So here is a stage 3 patient. We're able to find functioning lymphatics, and she totally weaned off from doing compression, and has been maintaining this kind of result after a few years of doing the LVA. This is the same patient that I just showed you, and in a week, the patient fluid deflated so much after finding that functional lymphatics. Remember, the majority of the lymphatic vessels are fibrotic, but you're able to find functional lymphatics, and if you hook it up, this is a good result. So our results for late stage 2 and stage 3, we could average around 5 LVA, and then it actually shows a clinically significant improvement compared to prior to surgery, and post-surgery, there was a significant improvement of the circumference. So here's a typical way. I don't know if you hear volume. So that's the basic way we approach. And again, it's creating a lymphovenous shunt, understanding how the pressure works, and then applying external compression, and eventually able to reduce volume and reduce the incidence of cellulitis. Now, even though we don't see reduction of volume, we definitely do see reductions, clinically significant reduction of cellulitis, which really helps the patient as well. Now, you've been listening to my video and my talk and emphasizing how important it is to find good lymphatics as well as ideal vein structures. And there's a lot of preoperative studies that we use. The most common preoperative study is LymphSynthi scan. And these basically give you a sort of a functional concept whether or not the lymphatic fluid is flowing through that groin lymph node and then ultimately toward the heart. Now, this actually shows that there is severe backflow, and the flow of the isotopes to the right groin is very slow. Now, in these patients that have lymphedema, ICG is also a very common way to study. And you can see here for stage 1, it's very nice to see, and possibly for stage 2 as well. But as the patient becomes more swollen up with thicker fibrotic layers and more swelling fluid collection in the extremity, the image does not really tell you much except stardust pattern. The limit of the ICG is that the penetration of that ICG, that infrared, is only 1 centimeter. So you have to ask yourself, just because we don't see lymphatic structure in stage 3, does it mean that there's no functional lymphatics? No, we cannot say that because the penetration rate is only 1 centimeter. So how do we identify whether or not there are functioning lymphatics underneath that 1 centimeter of plane? And this is where MRI lymphangiogram becomes in very handy in these advanced lymphedema patients, because with the lymphangiogram, MRI lymphangiogram, it actually shows you whether or not the patient has deeper lymphatic structures that are functioning. So with that in mind, we're able to actually do we're actually able to know whether or not there's functional lymphatics, and then we're able to plan an LVA. Another way to also see whether or not there are functional lymphatics is using gamma probe. You basically inject the isotope like in malignant melanoma, and then you trace it along and see if it reaches the groin. So if it does reach the groin, that we know that there are functioning lymphatic vessels. The limit of the gamma probe is that it really doesn't tell you exactly where the ideal lymphatic vessels are. Now, in our practice today, the biggest game changer is now the ultrasound, because the ultrasound is actually able to show you whether or not you have a dilated or a patent lumen lymphatic vessel. In addition to that, if you look into this photo here, it also tells you where the nearest vein is. Where's the nearest vein? So we're able to identify a functional lymphatics as well as where the nearest vein is, and map out everything even before the incision. So this has been a wonderful game changer for us. Now, you could also do this, but it's a little bit difficult with a relatively regular ultrasound with 8 to 15 megahertz. But with the ultra high frequency ultrasound, which is 45 or 75 megahertz, you're able to actually see the anatomical image of that lymphatic vessels very clearly, knowing exactly the depth of where it's located. So having these ultra high frequency ultrasound really has been a game changer for us. So the key is identifying deep lymphatic vessels that are functioning. In addition, identifying the vein and then doing the LVA. So the preoperative studies, there are many modalities that you could use, but for us, I think the duplex or the high definition ultrasound really has been the game changer, especially in doing LVA. I think Nicolas will go ahead and share more of his cases in regards to the LVA. Now let's go and see the lymph node to vein. So the lymph node to vein, if you think about it, if you look at the circulation of the lymphatics from the leg, theoretically, because most of the cancer patients are removing the lymph node in the pelvis because of the cervix cancer or the prostate cancer, these groin lymph nodes are usually intact. So theoretically, if the lymphatic system is working distal to the obstruction, then if we're able to hook up the node into the vein, it should be able to drain high pressure lymphatics. But if you look at this LymphSynthi scan, it doesn't really show whether or not there are functional lymphatics or not, because of the obstruction. The flow to the groin is so slow. And this is where MRI imaging comes in. And then you're actually able to see whether or not there's large lymph nodes. And according to our study, which is going to be published in PRS soon, if we see a lymph node that is larger than 0.8, then there's a high probability of that lymph node functioning. And if you find a lymph node, then it's a candidate for LVA. Now, this idea of connecting the lymph node to the vein is a very good idea, and it's been around since the 70s. And there's the Polish group who's published a lot of papers. And in this group, they actually cut the lymph node into half and then attach it to the large femoral vein. And because of the high pressure, it drains. Also, the Japanese group also reported using the efferent, a going out lymphatic vessel, and hooking up to the vein as well. But what we've been doing is we've been hooking it up by making a hole into the lymph node itself. And this allows to capture the flow, not only that are coming in, but also that are coming in backwards from the high pressure. So able to capture as much lymphatic fluid as possible. And our data actually shows that when you do lymph node to vein, you actually have a better result, especially in the thigh. Before we review that data, this is typically how we do lymph node to vein. You could actually see that we've opened up a little bit of the lymph node here. You can see the shining structure, and then you see that we've pierced, we've made an opening in the capsule, and we're dilating this opening. And when you dilate, you could actually see lymphatic fluid coming out. You could see the clear fluid coming out. So that's a good indication that the lymphatic fluid is coming out from the node. And once we see that clear fluid coming out from the node, then we go ahead and hook up the superficial vein into the capsule, able to drain the high pressure lymphatic fluid into the superficial vein. Remember, the lymph node captures multiple lymphatic vessels going to the node, and you can see how much clear fluid is coming out. And once you see that, you hook it up, and basically it's a standard microsurgery. So you don't have to worry about doing 0.3, 0.5. These are very large structures, and then you could hook up the superficial vein to the capsule and able to drain from that lymph node. So this is the idea of lymph node to vein. And our results show that doing lymph node to vein and doing it on functional lymph node to vein actually has, excuse me, a more positive result, a more faster result in regards to overall volume of the leg, as well as faster reduction of the upper thigh. So we know that the lymph node to vein also can contribute to the overall result of the lymphedema, as shown in this patient here after the surgery. Finally, we'll like to cover the lymph node fat flap. And this idea is basically replacing what is missing, like with like. Now, nowadays, we do quite a bit of amount for the upper extremity, because the upper extremity, if you look and think about it, it's the axilla portion that the lymph nodes are missing. At the same time, when they remove the lymph node, they cause severe scarring. And because of the scarring, the fat layer is disconnected completely by scar. So there's no chance of lymphangiogenesis. So we have to open up the axilla anyway to remove the scar and to create that continuity of the fat. Now, a lot of the cases, because they remove the lymph node and a lot of fat, there's just a large dead space. In this case, we go ahead and we put in a lymph node flap from we like to use from the groin, and then make sure that we reconstruct fat to fat continuity and to allow the chance for lymphangiogenesis into the node. Now, you could harvest multiple lymph nodes from anywhere. I know that Pedro likes to do the peritoneal flap as well. You could do submental, whatever you like. But again, when you open that scar, it causes a large dead space. And for us, the groin really works well because it's also an easy place to harvest. So again, we like to do in the upper extremity, after removing the scars, For stage 2 and stage 3, we like to do it together with the LVA and doing the node flap. Now for the lower extremity, because now we're able to identify functioning lymphatics even in stage 3, the use of the lymph node flap in the lower extremity has really gone down significantly. Nowadays, we like to do lymph node flap in cases where LVA didn't work. And of course, there's many places you could put in the lymph node. We like to put it in the ankle. So this is a typical way how we like to harvest the lymph node. Nowadays, it's just doing a groin flap. So this is the case where we like to just use the fat if you don't need a large volume. So underneath the superficial fascia, we're going to harvest a large volume of fat. We also like to use reverse mapping to make sure that the lymph node that we're taking is not a major functioning one, and then just take it as a lymph node fat flap. Now, majority of the cases, instead of doing the small volume flap, if there's a huge dead space in the axilla, we like to take the whole skip, deepithelialize part of it, and then hook it up to the thoracodorsal system, and then obliterate the dead space and make sure that we recover that continuity of the fat in all the planes. So for the arm, complete scar removal, identify recipient vessels, combined with LVA, and then we do the lymph node flap, and the results are shown as seen in this patient. I think for me, it just makes more sense to do lymph node transfers in the axilla because we're removing the scars anyway. But I know that Dr. Minghui Chen's group does a lot in the wrist. I think this has to really do it, and he has shown clearly that it also works as well. But since we're opening the axilla to remove the scars, for me, it just makes sense to do it in the axilla. For the lower extremity, I just mentioned to you briefly, we rarely do it now because we're able to find that functional lymphatics. But if we need to do it, we like to go ahead and do it in the ankle because it's just more easy to find good recipient vessels in the ankle. Now, there's been a lot of report in modification of the lymph node transfer, and I think Nicolas is going to talk about the lymphatic duct transfer, where you're just taking the subcutaneous fat with the lymphatic vessels. Of course, you could also take the lymph node with the tissue, and then you could also connect the vessels from the lymph node directly into the site where it's joining. So there's a lot of modifications in the lymph node transfer, or the concept of doing lymph duct transfer as well. Now, our first line for the arm is LVA with lymph node transfers most of the times. And in the lower extremity, we like to find functional lymphatics and base it on the availability. If we compare our old results, just looking at the lymph node flap versus the LVA, then obviously you know that the lymph node flap is just going to take at least 3 to 6 months to basically work. However, the LVA always shows improvement, significant improvement in the first month. If you don't see that significant improvement in the first month, then it's not functioning, or the patient is not being compliant to compression. So the biggest postoperative management that we have is emphasizing compression and exercise. And of course, we measure the improvement by measuring the circumference, by using bioimpedance analysis to see how much fluid has reduced, and also monitor the recurrence of cellulitis. Our initial results show that there has been a good subjective improvement because these patients were neglected all the time. If we just open up a little, and they're very happy. But nevertheless, the objective improvement was about 2/3, 78 to 68% in upper and lower extremity. Our biggest indicator whether or not to consider LVA is whether or not the patient has a collection of fluid. So that's having a pitting is a big indicator for us. So looking at through our experience, if we look at the overall approach for the upper extremity, we always, for acute lymphedema or for stage 1 or early 2, we send it to rehab. If the decongestive therapy doesn't work, then we start thinking about the surgical approach. Most of the times we'll take a look at the axilla, and if there's a lot of scarring, we'll open it up. We'll do LVA simultaneously with lymph node transfers. If we see a minimal scar, then we'll just consider doing LVA. If that doesn't work, we may do it one more time. For stage 3, we don't send it to rehab. We just go directly with lymph node transfers and LVA. And if that doesn't work, then you have to consider debulking surgery. For the lower extremity, again, for stage 1 or early 2, we'd like to send it to our rehab, make sure that the patient gets an opportunity to go under decongestant therapy. If that doesn't work, of course, for stage 3 or for patients that has the decongestant therapy doesn't work, then we consider LVA and lymph node to venous anastomosis, depending on the availability of the lymph nodes. And if that doesn't work, then we may consider secondary lymph node transfers. And if that doesn't work, then again, liposuction and debulking procedures. So that's our basic algorithm, but there are exceptions to this approach in patients where they're taking groin lymph nodes from malignant melanoma, especially in the foot. In these kind of cases, we may consider doing a lymph node flap with the skip flap simultaneously, and then this will be the result. The patient may undergo minimal lymphedema. They may have early transient lymphedema, but ultimately their lymphedema would get better with this kind of approach. Patients who has undergone a lot of radiation. This is a patient with a sarcoma and a radiation. In this case, again, with lymph node and skip, we're able to help this patient not only to provide good coverage, although it partially, but again, to improve the lymphedema as well. There are a lot of studies and new approaches, especially the preventive lymphatic surgery, and I know Nicolas is going to touch on that. Hopefully, we'll learn more about where's the evidence and where is it going in regards to preventive lymphatic surgery for the upper and the lower extremity. So looking back, we talked about what is lymphedema, why does it happen, what is the physiology, what is the idea behind lymphedema surgery, why is compression and exercise important in conjunction with surgery. We also looked at multiple treatment options. And finally, we also looked at a brief strategic algorithm of the approach. And hopefully Nicolas will be talking about in a little bit more detail in regards to other lymphedema that are especially formed from trauma or preventive LVA or new innovative surgeries like the lymphatic duct transfer. I think one of the most important things when you start off with lymphedema surgery is that it takes a long learning curve. And when I started to learn about lymphedema surgery in 2005, when I went to Dr. Kuchima, and I think some of you already heard the story that, I was looking under the microscope and he goes, JP, this is a lymphatic vessel. And it says, oh, it looks like a fiber. I don't see anything. And then he goes, oh, come to the operating side. And I go there and looking and basically I couldn't really know whether or not that was lymphatics. It was such a new world that it was very difficult to understand that was lymphatics. And the most important thing, the reason why I'm telling you this, because when you start doing this, you have to believe that the anatomy is there. You have to believe that it will work. Because it took me around 4 to 5 years. And in the beginning, I had to give up LVA because I wasn't sure if it was working or not. And this is why I transitioned for a long time to do lymph node flaps. But ultimately, as I did surgery and as I start to do more and more lymph node surgery, I start to understand the anatomy of the lymphatics. And it just takes a long learning curve. So don't give up and believe it works. And then one day you'll become a lymphatic surgeon, you'll become a super microsurgeon. Your patients will definitely pay off. This is an ongoing science. So there's a lot of questions that we don't know. This is just part of a preliminary finding. And of course, again, you have to be patient and you have to build your technical skills slowly. But the most intriguing part of being a lymphedema surgeon is that for every 1 out of 100,000 primary lymphedema in children, for the 15 to 20% of patients that have lymphedema after lymph node resection, and they didn't realize that there was a treatment for lymphedema, we are the surgeons who gives them hope. If you don't give up in doing this kind of small vessel surgery, super microsurgery, you will be that beacon of hope for those patients that did not have this kind of physiological solution in the past. So with that, I'd like to now transfer the mic and the podium to Nicolas, and hopefully he will fill in the void that I talked about. So thank you again for the invitation. And Nicolas, it's up to you now. Thank you.
Thank you, JP. That's very nice presentation, very impressive results. I agree with you that super microlymphatic surgeons should know anatomy and physiology of the lymphatic system. I think it's one of the key points to success in lymphatic surgery. So now we go with Nicolas. Please, Nicolas.
Okay. Yeah. So I will share my screen. Can you see it?
Yes.
Okay. I will put full screen. Okay. Can you see it, Pedro? Is it okay?
Yes.
Okay.
Yes.
So, well, we talk about some hot topics about surgical treatment of lymphedema. First of all, I would like to say that for me, it's a great honor to share this panel with my good friend JP Hong, that it's also my mentor, and with my also good friend Pedro. There is a picture when we did a pisco sour competition, Chile against Peru. Actually, I don't remember who won, but it doesn't matter. Sorry, JP, I will do my lecture in Spanish. I will have my slides in English if you want to follow it, and I will continue Spanish. Entonces, muy buenas noches, amigos. Gracias a todos por estar conectados. Y lo que voy a hablar son principalmente tres cosas respecto a temas que considero que son temas calientes en cirugía linfática, los hot topics. Primero, 7 pasos para tener una anastomosis linfático-venosa exitosa. Luego voy a hablar un poco del enfrentamiento preventivo del linfedema. Y finalmente voy a terminar con el linfedema postraumático, cómo tratarlo y prevenirlo. Partamos entonces con anastomosis linfático-venosa. Esto es un poco de algo que presenté en Patagonia Microsurgery Meeting. Los que tuvieron la oportunidad de ir van a ver algunas cosas que les va a sonar conocidas, y los que no, los esperamos próximamente cuando lo hagamos nuevamente y retomemos nuestra vía normal, que seguro que todos tienen ganas de participar en un congreso real y vernos cara a cara. Bueno, revisé la estimación de la población que tiene linfedema de los países que componen la ALAM, y me llevé la sorpresa que tenemos aproximadamente 22 millones de personas con linfedema dentro de los países que componen nuestra asociación, que es un número bastante alto. Y como dijeron y dijo JP, hay numerosos tipos de tratamiento para el linfedema. Ahora les voy a hablar específicamente de la anastomosis linfático-venosa. Esto lo mencionó hace un rato. La anastomosis linfático-venosa no es más que hacer algo que existe en nuestra anatomía desde el punto de vista fisiológico, pero nosotros lo hacemos a nivel periférico, en las extremidades, saltándonos o bypaseando la obstrucción. Fue escrita en los años 60, a finales de 60, en el año 69, por Yamada en Japón, y luego perfeccionada, y es por eso que hoy en día funcionan, porque Isao Kojima luego habló del enfrentamiento supermicroquirúrgico, y aquí la clave es que estamos usando vénulas, usamos pequeñas venas que no tienen reflujo, y así permiten que la anastomosis linfático-venosa sea exitosa usando una vena adecuada. El primer paso que considero importante es tener un instrumental y un equipamiento adecuado. Lo mencionaron previamente, pero voy a solamente recordar que para lo que yo creo que es fundamental, tener linfografía con beta-indocianina, linforresonancia, microscopios que sean potentes con la capacidad de magnificación adecuada, suturas 11-12-0, muy pequeñitas, eso que ven ahí es una semilla de sésamo, y por supuesto portaagujas para manipular estas suturas con punta de 0.1 milímetros. Luego que tenemos el instrumental, tenemos que hacer un estudio y planificación preoperatoria adecuado y preciso. Para eso, bueno, una buena historia clínica del paciente hace en la mayoría de los casos el diagnóstico, y es muy importante poder tabular y objetivar los síntomas del paciente. Esta es una escala que validamos al español, un cuestionario de calidad de vida que nos permite objetivar síntomas subjetivos y así ver cuánto impacta nuestra intervención en la calidad de vida de los pacientes. Está libre para el que quiera, miembro de la ALAM en español, en la revista chilena de cirugía. Y también estimamos los volúmenes, somos bien estrictos en medir en la misma posición de la extremidad los perímetros, y de esta forma, con la fórmula del cono trunco, calculamos una volumetría estimada de la extremidad y la comparamos con la extremidad sana. La linfocintigrafía yo la reservo para casos con duda diagnóstica. Considero que no me entrega tanta información como los otros dos estudios que les voy a contar a continuación, pero la linfocintigrafía la reservo para estudiar un edema que no me queda claro su origen. La linforesonancia considero que es muy importante por las razones que mencionaron antes. La linfografía con beta-hidroxianina nos permite penetrar 1,5 centímetros máximo. La linforesonancia nos permite ver el espesor completo de la piel en 360 grados y así poder mapear y hacer una cirugía mucho más precisa. Como por ejemplo en esta linforesonancia que podemos ver claramente el vaso linfático y la vena, y es lo mismo que vemos al momento de realizar la cirugía. Y la linfografía con verde indocianina, ustedes la conocen, consiste en inyectar este contraste fluorescente y con una luz con fluorescencia cercana a la infrarroja, uno puede captar dónde está el drenaje linfático en tiempo real y ver el grado de función o de disfunción de este sistema linfático, como está descrito los diferentes tipos de dermal backflow o patrón anormal de disfunción del sistema linfático. Acuérdense de estos patrones porque es muy importante para lo que yo les voy a mencionar en unas diapositivas más. La limitante que tenemos en países de este lado del mundo, no tanto en Asia, pero sí en Occidente, que el verde indocianina es bastante caro. Nosotros nos cuesta aproximadamente la ampolla unos $250. Por lo tanto, lo que nosotros hacemos es el Green Day, que juntamos varios pacientes. Esa ampolla tiene 5 cc, por lo tanto nos alcanza para 8 o 10 pacientes para hacer tanto diagnóstico y planificación. Y el día del Green Day marcamos al paciente el patrón que tiene, tomamos fotografías estandarizadas y aquí tenemos dos alternativas. O le decimos al paciente que se lleve un Sharpie para la casa para que se marque todos los días hasta el día de la cirugía, o lo otro es usar ARM-PS for LBA. Esto lo describimos y está publicado en el PRS si lo quieren revisar, pero es hacer la linfografía con verde indocianina el Green Day, marcamos la anatomía linfática y el patrón que tiene el paciente, tomamos fotografías estandarizadas y al día de la cirugía no realizamos nuevamente el examen. Lo que sí hacemos es importar estas fotografías a nuestro celular y con una aplicación de realidad aumentada superponemos las imágenes y marcamos el patrón que meses previo el paciente tuvo el momento del Green Day. Es así como nosotros podemos planificar el día de la cirugía, dónde van a ir nuestros abordajes para tener una cirugía precisa, sin necesidad de hacer nuevamente el examen, no perdemos tiempo, no hacemos al paciente gastar más dinero. Ahí está el patrón del paciente, planificamos nuestras incisiones y vemos que nuestra planificación fue bastante precisa. Se la tomó linfático venoso en el pie, esa en la pierna y ese es en el punto de Secchi a nivel de la rodilla. Y miren cómo coinciden con nuestra planificación hecha previamente con ARM-PS, que es la utilización de realidad aumentada para la planificación microquirúrgica. Bueno, cuando revisé y he visto presentaciones de otros grupos, por ejemplo, este es un grupo austríaco, ellos reportan un 90% de coincidencia de su preoperatorio con los hallazgos intraoperatorios, o este grupo japonés que reporta un 96% de match entre el pre y el intraoperatorio. Nosotros, afortunadamente, hasta ahora tenemos una concordancia con nuestro estudio preoperatorio del 100% y en todos los casos hemos podido realizar anastomosis linfático-venosa de nuestro abordaje. Por lo tanto, creemos que este enfrentamiento para planificar es bastante preciso. El punto 3, entonces, ahora tener una correcta indicación para el paciente individualizada en cuanto a su cirugía. Esta es la clasificación de la Sociedad Internacional de Linfología, que quiero que la vean acá, que es lo que mostró JP hace un rato, que mientras vemos a mayor severidad de la tipificación clínica, vamos viendo más contracción o esclerosis de vaso linfático, pero eso no es al 100%. Si ustedes ven en este gráfico que en etapa 0 hay una funcionalidad completa de los vasos linfáticos, en etapa 3 hay un alto porcentaje de vasos linfáticos escleróticos, que son vasos que no nos sirven para la anastomosis linfático-venosa, pero todavía hay un porcentaje de vasos linfáticos que tienen funcionalidad, y esto también lo reportó Takumi Yamamoto, que muestra, dependiendo de la clasificación de linfografía con verde indiocenina, cuando tenemos patrón lineal, hay un 100% de funcionalidad linfática. En Stardust o polvo de estrella tenemos un 70% de funcionalidad. Y cuando ya tenemos en el patrón difuso, hay solamente un 53% de funcionalidad, lo que no deja de ser importante. Por eso no tenemos que decir que si es patrón difuso no hay vaso linfático funcionante. Eso no es cierto, siempre van a haber, pero en un porcentaje menor. Y así como nosotros indicamos nuestra anastomosis linfático-venosa en extremidad superior, linfedema extremidad superior, en etapa 2 del patrón de dermal backflow, que eso quiere decir que hay un Stardust proximal al codo, solamente un 70% evoluciona al linfedema, por lo tanto inicialmente es un tratamiento conservador, lo mandamos a fisioterapia, como mencionaba también JP. En etapa 3 de dermal backflow stage, distal al codo que haya Stardust, todos estos pacientes van a evolucionar a linfedema, por lo tanto indicamos anastomosis linfático-venosa. En extremidad inferior somos un poco más estrictos. En etapa 1, eso quiere decir cuando hay splash a nivel proximal, por ejemplo en la ingle, aquí indicamos ELVA o Lymph Node to Vein, anastomosis linfonodo venosa. ELVA, luego les voy a explicar lo que es. Son etapas subclínicas estas. Y en esta etapa 2, que es el Stardust a nivel proximal, todos esos pacientes van a desarrollar linfedema, por lo tanto hacemos anastomosis linfático-venosa. Cuando ya tenemos la indicación adecuada, tenemos que ver dónde vamos a localizar nuestra anastomosis linfático-venosa. Y el lugar ideal, hay muchas zonas donde uno puede localizarla, pero el lugar ideal es dependiendo de la funcionalidad. Miren esta paciente con linfedema extremidad inferior. En la fase inicial de la linfografía con verdiendocianina vemos un patrón lineal hasta el tercio medio del muslo, pero en la fase tardía ya vemos Stardust hasta el tercio proximal de la pierna. Eso nos habla, primero, que la linfografía con verdiendocianina debemos hacerlo en 2 etapas para que obtener mayor información y mayor rendimiento. Y nos va a decir en qué lugares hacer la anastomosis linfático-venosa. Les decía entonces que en esta paciente, por ejemplo, tenía en la etapa inicial lineal hasta el muslo, pero luego aparecía el de Stardust hasta el tercio medio de la pierna. Por lo tanto, la mejor localización para la anastomosis en esta paciente es, como se muestra en la figura, en la zona de overlapping o de transposición entre la fase temprana, la fase tardía o la fase de disfunción de dermal backflow con el patrón lineal. El quinto paso para tener anastomosis linfático-venosa exitosa ya es en el momento de la cirugía propiamente tal. Lo que primero hacemos es, bueno, yo no uso ningún tipo de tinta, ni azul patente, ni verdiendocianina intraoperatorio, ni lo que usa JP, que es una tintura que se ve amarilla. Una incisión de 1,5 o 2 centímetros, y lo primero que buscamos es la vena, porque la vena la vamos a encontrar justo debajo de la dermis o en la grasa superficial. Separamos los márgenes y hacemos una disección de la vena para tener mayor longitud. Entonces ahí estamos haciendo el abordaje. Vemos, bueno, con un bisturí frío, luego un electrobisturí punta colorado, yo lo uso con el corte en 7, encontramos la vena justo debajo de la dermis, disecamos aproximadamente 1 centímetro, yo clipo la vena a distal. Fíjense en la manipulación que tengo con mi mano izquierda de la Adson, no cierro la Adson en ningún momento, la uso como un gancho con los dientes de la pinza. Dejo la vena ahí abandonada, es una vena pequeña, por lo tanto tiene nada o muy poco reflujo. Luego viene la identificación del vaso linfático y la disección, y eso lo vamos a encontrar bajo la fascia superficial, donde encontramos los vasos colectores de mayor calibre que nos van a permitir una mejor potencia y efectividad de la anastomosis linfático-venosa. Y en esta parte lo hacemos romo, con un mosquito, o vamos disecando sin bisturí eléctrico, porque los vasos linfáticos muchas veces se nos pueden confundir con la fibrosis o la fascia superficial. Abrimos la fascia superficial, disecamos el vaso linfático, usamos un nylon 5-0 para hacer como un vessel loop para marcarlo y que no se nos pierda, y disecamos un poco el vaso linfático. Ahí estamos, ya abrimos la fascia superficial, vemos que ahí queda un poquitito de fascia, por eso la tomo con la pinza, que voy a cortar, eso es entre fascia y fibrosis, y justo abajo está el vaso linfático que se ve transparente, translúcido, no uso ningún tipo de tinta, y vamos a disecar un poquitito más con un mosquito fino, Aquí usamos instrumental de supermicrocirugía y vamos a pasar nuestro nylon bajo el linfático para dejarlo marcado y que no se nos pierda para cuando pongamos nuestro fondo. Luego, hacemos la anastomosis propiamente tal. Usamos 11 o 12,0 dependiendo del tamaño del linfático, bajo 11,0, bajo 0,3 milímetros o 0,4 milímetros, yo recomiendo 12,0. Sobre eso, 11,0 anda bien. No usamos clamp para no dañar ni la vénula ni el vaso linfático. Los vasos están libres en el campo, un fondo triangular para permitir que sea más fácil introducirlo por debajo y mantener siempre el campo bien limpio, sin sangre y lavando con heparina constantemente para evitar la desecación de los vasos. En promedio, más o menos 6 puntos. El primer punto se pasa en la pared anterior a las 12, luego a las 10, a las 8, a las 6. Luego damos vuelta al linfático y nos vamos a las 2 y a las 4. Vamos a ver aquí en el video. Entonces, fíjense cómo manipulo el linfático con mi pinza. No cierro la pinza, siempre la pinza abierta para no lesionarlo. Pongo un clip para que no haya riesgo de linforrea. Estamos hablando de anastomosis terminales cuando son términos laterales o usamos los dos cabos, no se hace esta parte. Es muy importante tener un disector, un dilatador de supermicrocirugía para poder dilatar este vaso ultra pequeño. Estamos hablando de un vaso de aproximadamente 0,4 milímetros. Y esta parte es muy importante. El punto, idealmente, primero, pasar la vena, porque es mucho más fácil pasar el vaso linfático desde adentro hacia afuera que desde afuera hacia adentro. O sea, la aguja desde adentro del lumen. Aquí muchas veces no se ve el lumen, lo que hay que hacer es sentirlo, sentir que vencemos la resistencia de nuestro punto y así, luego de que pasamos el primer punto, el vaso linfático se abre y los puntos siguientes van a ser mucho más sencillos. Si es que el primer punto lo pasamos bien dentro del lumen, los otros puntos son menos complejos. Bueno, y si dejamos las colas un poco largas para que nos permita manipular el vaso linfático y evitar que se enrede en el nudo siguiente. Por eso dejamos las colas largas del punto anterior. Y fíjese cómo manipulo muy poco el vaso linfático con mi mano izquierda, solamente la pinza cerrada o manipulando hacia los lados. 3 nudos hacemos, como les decía, colas largas. Y bueno, finalmente los 6 puntos en promedio pueden ser 5, vasos linfáticos más pequeños, incluso 3 puntos, que son chiquititos. Y aquí finalmente vamos a medir una anastomosis supermicroquirúrgica de 0,4 milímetros. Bueno, hacemos anastomosis terminales, terminolaterales, lateroterminales, dependiendo de lo que nos enfrentemos en el momento, o terminales bien pequeñitas, y aquí estamos hablando de vasos de menos de 0,3, o sea, nanomicroquirúrgico, una manipulación mucho más precisa y los puntos tienen que ser mucho más certeros, aquí no hay margen de error, y tenemos que ver si es que estamos preparados ya para enfrentarnos a la nanomicrocirugía. Generalmente yo hago anastomosis terminales, lo reportó Takumi, tienen una permeabilidad, una patencia a largo plazo con un porcentaje más alto, por lo tanto yo me gusta darle al paciente una mayor certeza de que su resultado va a durar mucho más tiempo, pero si es que encontramos una vena más grande, un linfático más grande, podemos jugar un poco con lateroterminal, que también tiene un muy buen resultado, o usar los dos cabos proximal y distal con dos venas o con la misma vena en Y, en una I, para poder optimizar los dos cabos y mejorar el drenaje de las dos zonas. Y los resultados son bastante sorprendentes, incluso de manera precoz. Esta es una paciente de 3 semanas, recién le voy a sacar los puntos. Miren cómo se ha descongestionado esa extremidad, la piel está blanda, muy elástica, y vemos que la piel ya está redundante, totalmente descongestionada. Veamos algunos resultados. Una paciente con linfedema extremidad superior, 4 años de evolución, 46% de exceso de volumen en la extremidad superior derecha. Hicimos 5 anastomosis linfático-venosa, la que tienen abajo ustedes a la derecha, 0,35 milímetros, muy pequeño. Mucha gente que no está muy de acuerdo con este tipo de cirugía dice que no sirve, pero miren cómo les voy a mostrar acá el patency test, que estrujamos la vena y vemos como poco a poco se va llenando por el flujo que va desde el vaso linfático a la vena, un vaso linfático muy pequeñito. Ya vemos la vena que está ingurgitada, o sea, esa es una anastomosis linfático-venosa funcionante. Y esta paciente que operamos, después de 6 meses, ahora tiene solamente un exceso de volumen del 21%, y esto nos habla de una reducción del exceso del volumen del 54%. Fíjese en la muñeca, el antebrazo, ya le aparecen los nudillos nuevamente. Y lo más importante es la mejoría en su calidad de vida. Tenemos un impacto y una mejoría de un 60%. Otra paciente, linfedema extremidad inferior izquierda, le hicimos 6 anastomosis linfático-venosa. Ella había tenido 14 episodios, perdón, esta no es la paciente, pero 14 meses postoperatorio, un episodio de celulitis pre, ningún episodio postoperatorio y una reducción significativa del 71% de exceso del volumen. Miren la pierna izquierda cómo está totalmente descongestionada y ya no tiene edema con pitting. Esta es otra paciente más compleja, linfedema bilateral de extremidades inferiores, con 10 años de evolución, un episodio de celulitis, 7.700 cc de volumen en cada una. Hicimos 3 anastomosis linfático-venosa por extremidad y a los 6 meses vemos la disminución significativa, alrededor de 400 ml en cada una de las extremidades. Miren la pierna como ahora ya parece pierna, tiene forma, aparecen los tobillos, y lo más impactante, y miren la mejoría de la calidad de vida, los síntomas antes de la cirugía en rojo, en azul después de la cirugía, 90% de mejora en su calidad de vida, y miren lo más importante de ella, que luego de 10 años se pudo comprar zapatos nuevos, y me escribe un WhatsApp diciendo, no te imaginas lo feliz que me has hecho después de esta cirugía, que es lo que queremos lograr con una cirugía que mejore la calidad de vida de los pacientes. Entonces aquí recapitulamos con los 7 pasos para tener anastomosis linfático-venosas exitosas, pero lo más importante es aquí pasarlo bien y disfrutar de la supermicrocirugía. Es un punto fundamental para todo aquel que le guste hacer este tipo de procedimiento. Vamos ahora, saltemos al otro tema para no atrasarnos mucho en esta noche. Vamos a hablar del tratamiento y enfrentamiento preventivo del linfedema, porque como dijo Sun Tzu, la mejor batalla es la que se evita. Si podemos evitarlo, mejor, porque el resultado va a ser, va a mejorar la calidad de vida de igual forma, y los resultados también son mejores a medida que hagamos nuestros procedimientos de manera más precoz. Lo reportó Takumi, que hay hallazgos subclínicos en la linfografía con verdidocinina que nos sugieren que puede evolucionar al linfedema los pacientes que tienen que tuvieron cáncer ginecológico o disecciones de pelvis, ganglioneras de pelvis, y lo clasificó de diferentes formas, pero lo importante aquí es saber que hay un procedimiento que existe que se llama ELVA, que es el Efferent Lymph Venous Anastomosis, que es la anastomosis del vaso eferente del ganglio linfático. Si recordamos la anatomía del ganglio linfático, por la parte distal llegan los aferentes linfáticos y por el hilio del vaso linfático sale el vaso eferente que va a una segunda estación de ganglio linfático, y así hasta llegar a los ganglios de la pelvis. Y esto es el vaso linfático que se utiliza para hacer el ELVA o Efferent Lymph Venous Anastomosis. Como lo describió él en su paper, se buscan los ganglios linfáticos bajo la grasa superficial, la fascia superficial, se identifica el efferent lymphatic, el vaso linfático eferente, y se hace una anastomosis linfático-venosa de ese vaso linfático, y así uno previene el linfedema de la extremidad contralateral. Le explico enseguida de qué se trata eso. Por ejemplo, esta paciente tiene un linfedema de extremidad inferior derecha. Le hacemos el estudio de linfografía con indocianina en las dos extremidades. Vemos un linfedema en la extremidad derecha por indocianina, y a la izquierda vemos un patrón lineal, normal. Pero en la fase tardía, fíjese que vemos el linfedema de la pierna derecha, pero en la pierna izquierda, que es la sana, vemos hallazgos subclínicos de disfunción. Splash a nivel de la ingle, que eso nos habla que con muy alta probabilidad esa paciente va a evolucionar al linfedema. ¿Qué es lo que hacemos entonces? Hacemos por un lado la anastomosis linfático-venosa de la pierna derecha, la afectada, y hacemos ELVA en la extremidad, en la ingle de la pierna sana. Aquí estamos enfrentando la ingle de la pierna sana, la pierna derecha, encontramos el ganglio linfático, su vaso linfático eferente es la vena del ganglio linfático. Aquí es muy importante no utilizar la vena del ganglio, porque lo que hacemos ahí es disfuncionar el ganglio si le quitamos su drenaje venoso. Por lo tanto, vamos a buscar una vena que esté adyacente a la zona operatoria, pero no la del ganglio linfático, y hacemos nuestra ELVA. Esta fue la primera ELVA que se hizo en Latinoamérica, por eso guardo las fotos con mucho cariño. ¿Y cómo quedó la paciente? Bueno, estos son 22 meses postoperatorios. Miren la pierna derecha, hicimos 4 anastomosis linfático-venosa en la pierna afectada, más el ELVA en la pierna sana y la izquierda. Ella tenía 11 episodios de celulitis en los 2 años de evolución de su linfedema, 22 meses, o sea, casi 2 años después de la cirugía, solamente un episodio, y miren la reducción del volumen de un 50%, bajó a un 22% el exceso del volumen, eso es una reducción del exceso del volumen del 55%, y si se fijan los volúmenes arriba, la pierna sana sigue estando sana, porque hicimos un ELVA y además mejoramos la pierna que está afectada. Es el enfrentamiento preventivo del linfedema de extremidades inferiores en una extremidad subclínica. Y la mejoría, por supuesto, de su calidad de vida de esta paciente alrededor del 56%. Pasemos ahora al tratamiento preventivo, pero del linfedema secundario cáncer de mama. Eso que aparecen ahí son los factores de riesgo de desarrollar linfedema secundario cáncer de mama. Obviamente hay muchos que no podemos intervenir porque es parte del tratamiento oncológico, no podemos intervenir en esa parte. ¿Dónde podemos intervenir? Evitando que la paciente engorde o que suba de peso, o estimulándola que baje de peso, porque eso va a evitar que progrese el linfedema o que debute. Y el otro momento que podemos intervenir es al momento de la disección axilar. ¿Cómo se hace? La clave acá es identificar los vasos linfáticos que drenan la extremidad superior, porque muchas veces se lesionan durante la disección axilar. Y eso es lo que se llama una cirugía de reducción de riesgo de linfedema. ¿Cómo lo hacemos nosotros? Al momento de la cirugía del cáncer de mama, nosotros hacemos el estudio con linfografía de ardindocianina en esa extremidad, que recuerden es una extremidad sana porque la paciente se acaba de operar del cáncer de mama. Y lo que vamos a ver, por supuesto, es un patrón lineal hasta la axila, y lo que nos importa es ver cómo está a nivel de la axila, y en este caso, ¿qué es lo que vemos? Vemos fluorescencia, o sea, vemos filtración. Entonces, en ese momento, ingresamos con nuestro microscopio, con la fluorescencia, y identificamos los vasos linfáticos que están filtrando fluorescencia, por lo tanto, son los vasos linfáticos lesionados que drenan la extremidad superior. Además, vamos a identificar otros vasos linfáticos, que son los vasos linfáticos fríos, que no están fluorescentes, y los clipamos porque aquí disminuimos el riesgo de hacer seromas o linfoceles, y probablemente estos vasos linfáticos son del tórax o de la mama. Pero los vasos linfáticos calientes, los fluorescentes, vamos a anastomosarlos a una vena, y hacemos entonces anastomosis linfático-venosas inmediatas al momento de la cirugía, y de esta forma reducimos el riesgo de linfedema porque restituimos el flujo linfático de esa extremidad superior derecha, izquierda en este caso. Miren, la vena está fluorescente en todo su trayecto, eso nos habla que hay una anastomosis, bueno, en este caso 2 anastomosis linfático-venosas permeables con el paso de la fluorescencia hacia la vena que anastomosamos. Veamos este otro caso entonces, también una paciente recién operada de un cáncer de mama, patrón lineal obviamente, vemos ahí la filtración, identificamos los vasos linfáticos lesionados, que son los que vemos en la fotografía, hacemos la anastomosis a 1 o 2 venas que encontremos en la zona operatoria, y que son anastomosis que tienen permeabilidad y persiste el flujo linfático de la extremidad superior. ¿Qué es lo que dice la literatura? Las revisiones sistemáticas y metaanálisis en estos estudios que se revisaron, por ejemplo, estos casos controles muestran que de 30% de los pacientes no intervenidos bajaron a 4% de los pacientes intervenidos con esta cirugía de reducción de riesgo, o en este otro grupo de 50% se redujo a 13%, y aquí es importante recalcar que es una cirugía de reducción de riesgo, no elimina el riesgo, pero sí lo baja de manera significativa al riesgo muy parecido que tienen los pacientes que se someten al linfonodo centinela versus los que se someten a una disección axilar. ¿Y qué es lo que vemos con la paciente que les mostré en el último caso? Operado del cáncer de mama izquierdo, vemos que las 2 extremidades se mantienen prácticamente iguales con 1 año de seguimiento, la paciente sigue usando su anillo en la mano izquierda, y eso nos habla que no tiene edema, y si vemos la volumetría, las 2 extremidades están prácticamente iguales a 1 año de seguimiento. Ahora vamos al tema final de la presentación, un tema bastante abandonado pero muy apasionante, que es el linfedema postraumático. Se estima alrededor de entre un 20 y un 30% de edema después de un trauma importante, y por lo tanto es un mea culpa que debemos hacer nosotros, porque muchos de estos pacientes son linfedemas postraumáticos y no hemos sido capaces de diagnosticarlo de manera adecuada y ni tampoco tratarlo. ¿Y por qué pasa esto? Porque la disrupción del sistema linfático superficial, que conocemos anatómicamente dónde se ubican las zonas de mayor densidad de vasos linfáticos y de drenaje linfático de las extremidades superiores e inferiores, si es que sufren accidentes, va a haber un mayor riesgo de desarrollar linfedema, como también fue reportado en este paper que estudiaban la reacción linfática luego de fracturas expuestas de pierna que se reconstruyeron con colgajos musculares, y no hubo restitución del drenaje linfático en estas piernas con colgajos musculares. ¿Qué es lo que hemos visto nosotros y también estimulado con estos reportes de reacciones linfáticas? Vemos que pacientes que pierden mucho tejido, muchas partes blandas, no tienen ese pie cómo drenar su sistema linfático, y vemos al momento de hacer nuestro colgajo libre que junto a los vasos linfáticos, a los vasos sanguíneos, arteria, vena y en este caso el nervio tibial, también vemos dilatación de los vasos linfáticos profundos que habitualmente no los vemos. Ustedes cuando hacen disección de los vasos receptores no ven frecuentemente esos vasos linfáticos. Aquí podemos ver la anastomosis arterial y venosa, pero en este caso estamos viendo los vasos linfáticos profundos porque está drenando esa piel del pie en este caso, pero muchas veces no son suficientes para drenar territorios más extensos, y en esos pacientes es donde aparece el linfedema postraumático. Por ejemplo, esta paciente, una paciente añosa que le diseñamos ese colgajo, error, porque si nosotros vemos que el drenaje linfático pasa por ahí, hacemos el colgajo, ¿qué es lo que pasa? Nuestro drenaje linfático va a estar interrumpido, no va a seguir en continuidad, y ¿qué va a pasar? Por supuesto, esta paciente va a desarrollar un linfedema distal a la cicatriz. Por esta otra paciente, una mordedura de araña que diseñamos un colgajo propeller. ¿Qué es lo que pasó con esta paciente? Desarrolló edema distal a las cicatrices, y si le hacemos el estudio, un linfedema producto de la mordedura de araña, y después al diseño del colgajo que cambiamos el eje del drenaje linfático de esa extremidad. O en esta otra paciente que hacemos reconstrucciones más complejas, colgajo microquirúrgico, pero ¿qué es lo que apareció? Pitting distal a las cicatrices, y si hacemos el estudio con linfografía, un patrón de disfunción linfática, y eso nos habla de un linfedema postraumático. También se ha reportado que es importante mantener la axialidad del drenaje linfático de los colgajos una vez que hagamos reconstrucciones de partes blandas, y por eso nos preguntamos qué es lo que está pasando acá, qué es lo que estamos haciendo mal y cómo podemos resolverlo. Nosotros propusimos esto el año pasado, publicado en Microsurgery, el tratamiento postraumático con el SKIP-L, que es el colgajo SKIP, incluyendo los vasos linfáticos y considerando la axialidad de ese drenaje linfático, que lo vamos a ver ahora a continuación, que nosotros le llamamos TEAR, que significa el Total Extremity Anatomy Reconstruction, en la anatomía total de la extremidad, no solamente en las partes blandas, sino reconstruir la funcionalidad del sistema linfático. Hicimos un trabajo prospectivo durante el 2018, con seguimiento de más de un año durante el 2019. Hicimos a todos nuestros pacientes el estudio de calidad de vida, la medición de los volúmenes, y en los pacientes que tuvieron daño de partes blandas en zonas críticas, hicimos el TEAR preventivo con el SKIP linfático, y los pacientes con el linfedema instalado, con pitting, con edema con pitting y vaso linfático funcionante en el estudio por convertir indocianina, le hicimos el TEAR. ¿Cómo hacemos nosotros? Entonces estudiamos los vasos linfáticos de la región inguinal, los marcamos, planificamos nuestro colgajo microquirúrgico, un SKIP, incluyendo vasos linfáticos. Acuérdense que el drenaje linfático de la ingle va desde lateral a medial, desde el lateral hacia los ganglios de la ingle. Ese drenaje es muy importante mantenerlo en cuenta, porque al momento, bueno, aquí vemos los vasos linfáticos intracolgajo, y miren cómo drenan en los ganglios linfáticos de la ingle. Eso hay que tenerlo en consideración al momento de hacer la reconstrucción. Vamos a ver entonces nuestro enfrentamiento preventivo en zonas de riesgo de drenaje linfático que fueron lesionadas las partes blandas. Por ejemplo, este deforramiento, este degloving de la pierna por la cara interna, donde hay mayor densidad de vasos linfáticos, y hacemos el estudio con vermidocianina y marcamos los vasos linfáticos hasta el borde de la herida para hacer nuestro insert de manera precisa vis a vis de los vasos linfáticos. No es necesario aquí hacer anastomosis linfática, sino que basta con coaptar la grasa profunda de estos tejidos para que luego por una neolinfogénesis haya una inosculación de los vasos linfáticos y se restituya el drenaje. Como pueden ver acá, marcamos el borde de la piel, como vemos el borde con el vaso linfático lesionado. Y eso hacemos en nuestros pacientes. Daño partes blandas en las zonas críticas, reconstruimos con colgajo skip, manteniendo la axialidad del drenaje linfático. Y eso lo quiero graficar en esta reconstrucción. Fíjense estos vellos que se ven en el colgajo en la parte proximal de la pierna. Estos corresponden a vellos del pubis, por lo tanto la parte medial. Entonces esta es la parte lateral del colgajo, esta es la parte medial, esta es la parte distal de la pierna, esta es la parte proximal. O sea, el drenaje está restituido desde distal a proximal. Luego lo vamos a ver en más detalle con otro paciente. 6 pacientes tratados de manera preventiva, ningún colgajo falló, ninguno de estos pacientes desarrolló linfedema con más de un año de seguimiento. ¿Cómo lo hacemos cuando ya tenemos el linfedema instalado? Por ejemplo, esta paciente que tuvo un degloving de la región del codo que se injertó. Por supuesto, el codo no se debe injertar, ni menos si queremos mantener el drenaje linfático permeable. Ahí hay una interrupción del drenaje linfático, vemos tener linfáticos funcionantes hasta el nivel de los injertos. Hacemos anastomosis linfático, anastomosis del colgajo que elevamos. Hacemos un verdadero puente linfático manteniendo la axialidad del drenaje linfático para restituir en un segundo tiempo el flujo linfático de estos pacientes. La paciente antes de la cirugía tenía 27%, ahora tiene 12%. Fíjense en el antebrazo y la muñeca como ya aparece menos edematizada, ya no aparecen el edema del antebrazo y está usando nuevamente sus anillos en la mano, una reducción significativa del 56%, los síntomas en rojo antes y en azul después de la cirugía. Y vemos como luego de la cirugía hay captación proximal de los vasos linfáticos porque este colgajo está haciendo de puente linfático. ¿Cómo nos ha ido con estos 5 pacientes hasta ahora operados con más de 5 años, más de un año de seguimiento? 63% de reducción del exceso del volumen y 51% de mejoría de la calidad de vida. Finalmente pasamos en la última parte, que es el tratamiento en los pacientes que tienen daño limitado de tejido blando. Por ejemplo, este paciente que tuvo una cicatriz en una zona crítica de la extremidad secundaria a una cirugía traumatológica, tiene un linfedema distal de un 4% en esa zona del tobillo, que es lo que hacemos nosotros, anastomosis linfático-venosa, y luego de la cirugía tuvo una reducción importante de un 200%, esta pierna ya está más delgada que la pierna sana incluso, y esto es lo que nosotros llamamos, considerando todas las cosas que le mencioné previamente, el PLAST, que es el Post-Traumatic Lymphedema Algorithm for Surgical Treatment. Vamos a recordar brevemente. El TEAR lo hacemos cuando hay daño de partes blandas. Por ejemplo, este paciente con un daño en una zona muy crítica, tiene linfedema hacia distal. Hacemos una reconstrucción microquirúrgica con un skip, sin incluir ganglio linfático, solo vasos linfáticos, manteniendo la axialidad del drenaje, y el insert se hace con el drenaje linfático manteniendo la misma axialidad. Y después de la cirugía, esto es un año de seguimiento, tiene una reducción del exceso del volumen del 100% prácticamente. Y cuando no hay daño de partes blandas, hacemos anastomosis linfático-venosa. Por ejemplo, este paciente que trabajaba en el zoológico, lo atacó el tigre del zoológico, tuvo zarpazos del tigre a nivel del muslo y mordedura del tigre en la pierna. Obviamente este paciente desarrolló un linfedema distal. Miren el pitting, 13% de exceso del volumen, 3 episodios de celulitis. Cuando consultó, le hicimos anastomosis linfático-venosa y una reducción importante del exceso del volumen del 44% y sin episodios de celulitis a la fecha. Y finalmente, el último caso que les voy a mostrar, una paciente con una fractura expuesta. Miren, con un exceso del volumen distal a la cicatriz, no mucho, pero bastante significativo desde el punto de vista sintomático. Esta es la fase inicial de la linfografía con bernindocianina y esta es la fase tardía cuando ya aparece la disfunción distal a las cicatrices. Planeamos nuestra cirugía con RPS, con realidad aumentada, hacemos la anastomosis linfático-venosa distales y vemos cómo hay una reducción significativa distal a la cicatriz. La paciente con una reducción en este paciente muy significativa, incluso la pierna está más delgada que la pierna sana. Es bastante importante, un 300% del exceso del volumen, y creo que escucho de la paciente que ahora...
El 20 de marzo del 2018 tuve un accidente de tránsito con fracturas, un síndrome compartimental, que fue tratado, pero que finalmente también condujo a que tuviera linfedemas. Y se me hizo la cirugía justamente para tratar los linfedemas. A mí se me hacían unos edemas importantes alrededor del tobillo, que me generaban dolor y también molestia para caminar o para ponerme calzado. Y luego de la cirugía, a los pocos días, cuando ya me dieron de alta, empecé a observar mi pierna y realmente por lo menos un 50 o un 70% disminuyó la hinchazón y los edemas que se me hacían. Sin dolor, la verdad es que maravillosa la cirugía.
Bueno, eso lo quería verificar, que es muy importante que podamos ver la patología de estos pacientes. Y bueno, los mensajes que quiero que se lleven para la casa: primero, que las anastomosis linfático-venosas requieren una planificación y una indicación individualizada y muy precisa en el punto de vista de planificación, que debemos saber que existen tratamientos preventivos para el linfedema, porque nosotros no somos los que vemos a estos pacientes inicialmente, son los cirujanos oncólogos, y ellos nos deben llamar para poder prevenir el linfedema en esos pacientes en el momento oportuno. Y finalmente, que el drenaje linfático y el sistema linfático debe ser considerado en todas nuestras reconstrucciones de extremidades para poder prevenir o tratar el linfedema de estos pacientes. Muchas gracias por su atención y un gran abrazo para todos la gente de ALAM.
Thank you very much, Nicolas, for nice presentation. I think we have two wonderful presentations today. On the behalf of the Latin American Association of Microsurgery, we thanks both of you guys. There is a few time for discussion. We only have 2 minutes for discussion. So first of all, I would like to ask about which kind of complication have you had during this time that you are performing lymphatic surgery? JP?
If you're doing lymph node transfer, I guess there's always a risk of having flap failure. Most of the times when we do lymph node flaps, especially in the extremity, it's a buried flap, so the monitoring can become quite difficult. If you're doing LVA, if there's any complications really involved, I've had maybe a couple of dehiscence, skin dehiscence problem. But other than that, I think LVA itself is a very low risk surgery itself. So I don't know, Nicolas, do you have anything to add?
Well, unfortunately, in these times, we're not doing any lymphatic surgery because we cannot do any elective surgery. So during this COVID pandemic, we're not doing any lymphatic surgery, unfortunately. We are just doing emergency and free flap cases for trauma.
Okay, thank you. And the last question, just because we are on time, are you using, or what's your algorithm protocol for after surgery? When you perform LVA or lymph node transfer, what do you do? So do you do complex decongestive therapy? When do you start?
So this is a very important question, and I think what's really great about this webinar is that we could really go on and talk about this for a long time. I just want to quickly remind, before I answer this question, that there is a whole big session dedicated for lymphedema in WSRM next year in Cancun. So I know that it's hosted in Mexico. I'll definitely see a lot of there, and hopefully the COVID will be better, so we'll be free and to have beers together and talk about this topic. I think the biggest post-operative management for me is compression. We start immediate compression after LVA to really maximize that pressure gradient between the lymphatics and the vein. We're not really worried about the compression having effect on the anastomosis itself. And then we start walking the patient. If it's an upper extremity, we start hand exercise with a ball immediately. If it's a lower extremity patient, again, with compression, we start walking the next day, and then we discharged 2 days later. So I think in regards to your question, that would probably be the most important post-operative management.
How about you, Nicolas?
Yeah, after LBA, I start compression right away, right after the surgery. And after lymph node transfer, I start 4 weeks after the surgery. I wait a little bit. I don't want to do compression under the vascular anastomosis, but I totally agree that the compression after an LBA, it's you have to do it immediate after surgery. And we start compression, physical therapy, 2 weeks after surgery for upper limb and 3 weeks after surgery in the lower limb after we take out the stitches.
Okay, thank you very much. So lymphedema is a relative new field in plastic surgery, and there are a lot of controversies also. We can talk hours and hours, but unfortunately time is over. So we would like to say thank you, both of you guys. We really enjoy the presentation, nice cases, nice results, and most important is to share knowledge in this time, this difficult time. So thank you, Yepi, thank you, Nicolas. Please join next webinar session. It will be very interesting.
Stay safe, guys. Thank you.
Bye-bye. Good to see you all.
And
bye-bye.
Hang on a minute, because we had a giveaway today for the lymphedema book. Okay, for all the attendees, we did pick a random number. We made it 3 attempts, and winner number was number 24. It's Kelly Carrion.
Gané mi libro.
Open the mic.
So Kelly, estás como first. ¿Qué libro?
Tiene el micrófono abierto, habla.
Okay.
Sí, abrimos el micrófono para que dijera unas palabras.
Para Nelly.
Buenas noches. Muchas gracias. Realmente me siento muy afortunada. Thank you. I like all the expositions. They're so pretty great. I'm Peruvian. And well, I am following all the webinars and I'm so excited for winning the book. I will appreciate a lot of.
Oh, gracias.
Thank you, Kelly, and congratulations. And we'd like to invite you for our next webinar that is going to be June 17 on innovations applied to clinical scenarios with Tommy Nai from Changong and Jose Ramon Rodriguez from Chile. Also, check out tomorrow's social media of ALAM. We have great news that are going to be revealed tomorrow. And thank you again, Nico, Pedro, and JP for giving us the time and being part of ALAM for a couple of hours.
Thank you.
Thank you, guys. Stay
See you
safe.
guys. Take
Hope
care.
to see you soon.
Muchas
Bye-bye.
Los esperamos.
Chao a todos. Gracias.